Hi everybody, and welcome to our module on heart sounds. Shown on the screen is Wigger's diagram of the cardiac cycle, and I just want to point out to you that the heart sounds are found on Wigger's diagram. S1 is here, S2 is here, and through Wigger's diagram you can correlate the heart sounds to other events in the cardiac cycle, like changes in pressure at the top of Wigger's diagram, or venous pressure changes, or the EKG. The first two heart sounds we'll discuss are S1 and S2. These are the normal heart sounds. And each of these heart sounds has two components. One component comes from closure of left-sided valves like the aortic and mitral, and the other component from closure of the right-sided valves like the tricuspid and pulmonic. S1 is usually a single sound. Even though it's got two components, they are usually so close together that it's difficult to distinguish the separate sounds with your ear. S2, on the other hand, can sometimes be audible as a split second heart sound. In other words, the two components from the two separate valves that close to make up S2 can be far enough apart that you can audibly hear a split in the second heart sound with your ear. The two components of the first heart sound S1 are the mitral and tricuspid valves. When they close, those sounds make up S1. The two components of S2 come from closure of the aortic and pulmonary valves. If you look at the bottom of the screen, I've shown you how these heart sounds correlate with the ECG. So the QRS complex, as you know, is when the ventricles depolarize. And when the right and left ventricles depolarize, they contract. And that raises the pressure in the ventricles and closes the mitral and tricuspid valves. And that's what makes up the first heart sound. Usually the mitral valve closes a little bit before the tricuspid valve, but as I told you before, it's often difficult to distinguish the two separate sounds with your ear, and therefore S1 often sounds single. S2 is made up from closure of the aortic and pulmonic valves. This occurs later in the ECG tracing after relaxation of the left ventricle has begun, and the aortic valve usually closes a little bit before the pulmonic valve. And what I'm going to do now is play you an example of the two heart sounds S1 and S2, and what I want you to pay attention to is the fact that diastole is always a longer period than systole. So what you should hear is the lub-dub of S1 and S2 close together, and then you should hear a long pause, and then the lub-dub again. And one of the most basic skills with the stethoscope that it's important to obtain is the ability to distinguish systole from diastole. So try to do that now as we listen to the two normal heart sounds. As I mentioned before, there are a number of situations where the two components of S2 separate in time, and you are able to hear the splitting of the second heart sound with your ear. So let's go through these in the next few slides. So the first type of splitting that occurs in the second heart sound is called physiologic splitting. When you inspire and take in a breath of air, you lower the intrathoracic pressure, and this is transmitted to the right atrium, so there's a slight decrease in right atrial pressure. This draws more venous blood into the heart and increases venous return. What you always want to remember is that inspiration increases venous return. What this means in terms of the heart sounds is that there's going to be more blood in the right ventricle that has to be pumped out before the pulmonic valve can close. This means that the closure of the pulmonic valve is going to be slightly delayed. So let's look at this drawing on the screen. During exhalation, we've got aortic valve and pulmonic valve closure close together for the second heart sound. Usually you can't hear the two components. When the patient inspires, if you're listening to the heart, you can then hear the components separate in sound. This is called physiologic splitting of the second heart sound. It's caused by an increase in venous return that delays closure of the second heart sound by about 50 milliseconds, which is usually enough that you can appreciate it with your ear, and thus the second heart sound goes from single to split on inspiration. And I've got an example of that I'll play for you now. The first few beats are with exhalation, and then the patient inspires, and you should be able to hear the splitting of the second heart sound. Physiologic splitting of the second heart sound is a normal finding seen in patients with normal hearts, but there are some patterns of S2 splitting that can be seen in patients with certain heart pathologies. So let's talk about those now. Persistent S2 splitting is a finding seen classically among patients with right bundle branch block or also among patients with pulmonary hypertension. In both of these conditions, there is delayed closure of the pulmonic valve that causes a persistent split of the second heart sound. So in either of these conditions, when the patient is exhaling, the pulmonic valve closure is delayed because of the right bundle branch block or pulmonary hypertension. This creates a split in the second heart sound even during exhalation. When the patient inspires, then that split widens for the reasons we talked about on the last slide. So I've summarized this at the bottom of the slide. Delayed pulmonic valve closure causes persistent splitting of the second heart sound even during exhalation. And an easy way to remember this is to remember that persistent has an R in it, and that R is for a right-sided delay in closure of the pulmonic valve. Fixed splitting of the second heart sound is similar to persistent splitting, except for the fact that the degree of split of the second heart sound does not change in going from exhalation to inspiration. As I showed you on the last slide, in persistent splitting, the split widens with inspiration. In fixed splitting, the split is the same during exhalation and inspiration. And the classic cause of a fixed split of the second heart sound is an atrial septal defect. This is basically all you want to remember when you hear the term fixed S2 splitting. The reason for this is because in an ASD, there's increased flow on the right side of the heart. This delays closure of the pulmonic valve when the patient is exhaling and also when the patient is inhaling, and there's no change in that split during the respiratory cycle. So at the top right side of the screen, I've summarized the classic findings of an atrial septal defect just so you can remember these. It's a fixed split of the second heart sound and also a systolic ejection murmur at the left sternal border. The murmur is caused by increased flow across the pulmonic valve. And at the bottom of the screen, I've summarized the important points about flow across an ASD leads to increased right-sided flow. That's the cause of the fixed S2 split and also the cause of the systolic murmur. And I've got an example of a fixed split second heart sound, which I'll play for you now. The final abnormal pattern of S2 splitting is called paradoxical splitting. This occurs anytime there is delayed closure of the aortic valve, and there are a number of reasons for this that we'll talk about in a minute. So in this situation, when the patient is exhaling, the aortic valve has delayed closure, and thus it is split from the pulmonic valve component of the second heart sound. This is the backwards of normal. Normally, the aortic valve closes first and the pulmonic valve closes second. But in this case, we have pathology causing the aortic valve to close late, and thus a split is present in S2 at exhalation. When the patient takes in a breath, then the pulmonic valve closure is delayed for the reasons that it normally is in physiologic splitting. This brings the two heart sounds together. When you're listening to the heart, what you will see is a paradoxical split. You will see no split during inspiration, and you will hear a split during exhalation. This is the opposite of what's normal, and therefore it's called paradoxical S2 splitting. So what could cause delayed closure of the aortic valve and paradoxical splitting? Well, first of all, there are electrical causes. If a patient has a left bundle branch block or a pacemaker, which paces the left ventricle from the right ventricle, this will cause delayed closure of the aortic valve, and that can cause paradoxical splitting. There are also mechanical causes. These are processes that delay blood flow out of the left ventricle and therefore delay the closure of the aortic valve. This includes systolic heart failure, aortic stenosis, and hypertrophic cardiomyopathy. And an easy way to remember the causes of paradoxical splitting is to remember that paradoxical ends in L, and that L is for a left-sided heart delay in closure of the aortic valve. So here's a summary of the patterns of S2 splitting that you should know for step 1 of your boards. Physiologic splitting is caused by normal respiratory variation in venous return to the heart. Persistent splitting has that R in it for right-sided causes, including right bundle branch block and pulmonary hypertension. These all cause delayed closure of the pulmonic valve. A fixed split of the second heart sound is seen in atrial septal defect, and a paradoxical ends in L, and that L is for left-sided problems leading to delayed closure of the aortic valve. This includes left bundle branch block and cardiomyopathy. Shown on the screen is a cardiac phonogram. This test isn't done in the modern era, but years ago, before echocardiography was available, doctors would sometimes record the heart sounds and then convert them into an image called a cardiac phonogram. And this made it much easier to discern splitting and other features of the heart sounds that are much harder to appreciate in the modern era using only your ear. So for example, at the top of the screen is a phonogram of a normal S1 and S2, and you can see that the components of the two heart sounds, S1 and S2, are very close together, thus they appear to be a single structure in the image. This would be an S1 and this would be an S2. At the bottom is a phonogram of a patient with a fixed split S2, and you can see that the second heart sound shown right here clearly has these two components indicated by the two lines. So cardiac phonography, when it was used decades ago, made it much easier to discern the changes in the heart sounds that are much harder to do in the modern era using only your stethoscope. A loud P2 is a finding that is classically seen when there is pulmonary hypertension due to any cause. What people mean by a loud P2 is that there is a loud pulmonic component of the second heart sound S2, and anytime there's high pressure in the lungs, there will be forceful closure of the pulmonic valve, and this will lead to a loud P2. So for example, someone with left-sided heart failure can have a loud P2. Someone with primary pulmonary hypertension can also have a loud P2. And clinically, the way people often identify this finding is that normally you shouldn't hear the second heart sound very loud at the cardiac apex because that's far away from the pulmonic valve. And if you can hear it out here, people often say it's loud. Moving on, let's talk about the third and fourth heart sounds, S3 and S4. These are both usually pathologic or abnormal heart sounds, in contrast to S1 and S2, which are the normal heart sounds. S3 and S4 occur in diastole during filling of the left ventricle, and they are both low-pitched sounds, and low-pitched sounds are heard best with the bell of the stethoscope. This is a picture of a stethoscope here. The flat part is called the diaphragm, the circular part is called the bell, and that's best for hearing low-pitched sounds, which include S3 and S4. S3 is an early filling sound heard in early diastole. That means it's close to S2, as shown in this drawing on the screen. S4 is a late diastolic filling sound, therefore it's heard very close to S1. S3 is commonly heard in acute heart failure. When patients have high left atrial pressure, that high pressure causes rapid early filling of the left ventricle in diastole. And the way you can think about this is the high pressure in the left atrium just forces blood down into the left ventricle. The blood slams into the wall in diastole, and that causes the S3. And this has been shown clinically in studies where they have associated the presence of a third heart sound with high left atrial pressure and high left ventricular end diastolic pressure. These are both findings seen in acute heart failure. Some people say that patients with heart failure are pushers, meaning that they push blood into the left ventricle, and for this reason they get an S3. And an S3 is a very specific sign of high left atrial pressure. When I'm evaluating my heart failure patients, I listen for an S3. If I don't hear one, that's a good thing. I know that they are well compensated. If I do hear one, I worry that they're going into heart failure. Now, one thing you need to know about S3 is it is not purely an abnormal sound. You can sometimes hear this in normal hearts. The two situations where this can be heard normally is in young, thin patients, usually under 30 years of age, or in pregnant women. These two groups of patients are suckers, so they have very vigorous left ventricular relaxation, and that also pulls blood rapidly into the left ventricle and causes an S3, but not because of any type of left ventricular pathology. I mentioned this before, but S3 is best heard with the bell. It's also best heard if you ask the patient to lie in the left lateral decubitus position. This is an example of a woman shown in that position on the screen. When patients lie on their side and you listen to the heart with the bell or the stethoscope, it's often easier to hear S3. It's also loudest at the apex, the same place where you listen for mitral regurgitation murmurs. And now I'll play you an example of an S3. Try to listen for a heart sound that comes right after S2. Some people remember this sound as following the pattern of Kentucky, so it's Kentucky. The Ken is the S1, the Tucky is the S2 and S3 together. Now let's talk about S4. This heart sound is heard in patients with a stiff left ventricle. This is a sign of a stiff left ventricle. You can hear this in patients with long-standing hypertension who have left ventricular hypertrophy. You can hear it in patients with hypertrophic cardiomyopathy, and you can also hear it in diastolic heart failure patients. The cause of the S4 is rapid late filling of the left ventricle due to the atrial kick, and it's very important that you remember that you need contraction of your atria to cause this heart sound. For that reason, you won't hear this in atrial fibrillation, as is shown on the bottom of the screen here, because patients with atrial fibrillation have lost their atrial kick. So the idea behind the fourth heart sound is that the atrium contracts late in diastole, pushing blood into the left ventricle, and then that blood slams into a stiff left ventricular wall, and that causes the S4. I'll play you an example of the S4 now, and just like patients remember the S3 by Kentucky, patients often remember the sounds of an S4 by Tennessee. So they remember Tennessee, Tennessee. The tenna is for the S4 and the S1, and the C is for the S2. When we say that someone has an S3 or an S4, we are usually trying to describe a problem in the left side of the heart, but you should be aware that there are so-called right-sided third and fourth heart sounds. These are sounds that can occur because of a problem with the right ventricle, not the left ventricle. They have the same mechanisms as the left heart sound, so in right heart failure with high right atrial pressure, you can hear a right-sided S3. With right ventricular hypertrophy and a stiff right ventricle, you can hear a right-sided S4. These sounds are very difficult to auscultate at the bedside, but in board questions, you may read about a right-sided S3 or S4, and you need to be aware that they're talking about a problem with the right heart in that situation. The last topic for this video is systolic clicks. So systolic clicks are sounds that can be heard in systole, obviously, and this differentiates them from the extra heart sounds in diastole like S3 or S4. There are two systolic clicks that you need to know for step 1 of your boards. The first type is called an ejection click. This is called an ejection click because it occurs early in systole when blood is being ejected from the left ventricle. Importantly, it occurs before the carotid pulse. So if you're listening with your stethoscope and you have your fingers on the patient's carotid pulse, an ejection click will be heard before the carotid pulsation. And the cause of a systolic ejection click is a bicuspid aortic valve. A non-ejection click occurs late in systole after the carotid pulse, and the cause of this finding is mitral valve prolapse. So now let's talk about mitral valve prolapse. In this condition, there is stretching or billowing of the mitral valve leaflets above the valvular annulus. If you look at the bottom right side of the screen, on this drawing, this is a normal mitral valve. So you can see that the leaflets come together basically in a flat line at the level of the mitral valve. That's called the mitral valve annulus. In a patient with mitral valve prolapse, those leaflets are stretched and they billow up like a parachute into the left atrium. That is called mitral valve prolapse, and that is what causes the non-ejection systolic click. You should be aware that mitral valve prolapse often leads to mitral regurgitation. You can imagine that these stretched leaflets break down over time and the valve starts to leak. Also, sometimes mitral valve prolapse can cause one of these cords to suddenly tear, and that can lead to the abrupt onset of mitral regurgitation. The oscillatory finding of mitral valve prolapse is a systolic click, like I mentioned on the last slide. And don't confuse the systolic click of mitral valve prolapse with the opening snap of mitral stenosis. The opening snap is in diastole, a systolic click of MVP is in systole. And when I was a student, I always got these two things confused, so the way I remembered it is by the mnemonic I've written on the slide here. I just remembered that the two mitral valve disorders were not prolapse and stenosis, they were proclick and steno snap. Use that if you wish. The murmur of mitral valve prolapse is one of the hardest murmurs to identify just from the oscillatory findings. There's a systolic click like we talked about before, and then this is followed by the murmur of mitral regurgitation, because remember, MVP almost always leads to some degree of mitral regurgitation. In a board question, you're going to need help from the question stem to recognize this murmur. Most often, mitral valve prolapse will be described in either a young woman or a patient with Marfan syndrome. Those are the two classic demographics to develop this condition. But I'll play the murmur for you now so that you've heard it at least once. What I'm going to do is first play the S1 and S2 with the murmur of MR. That's all you're going to hear for the first beats. And then I will add in the click so that you can hear everything together, the S1, the click, the S2, and the murmur of mitral regurgitation. And that concludes our video on heart sounds.